Well, good evening, everybody. Welcome to the final session of MiniMed Fall 2023, the North Edition. Hopefully, as you all come in, you received an email about the next series that starts next Tuesday on the 14th. And so for those of you who missed one session and still want to qualify for your science certificate, and to be able to become a Delaware Youth Medical Academy member, there's your opportunity. And regardless, it'll be additional learning and you'll get more points and more badges. Okay, let's see how the numbers are coming right on along here. Okay, well, why don't we go ahead and get started. Normally, we do a PowerPoint presentation in the beginning. I think by this, the sixth and final session, you all probably know what MiniMed is about and what expectations are, and that it doesn't qualify for CE or CME and whatnot. What I did want to real quickly review with you is that about the reflection piece. So here's what we've mapped out, and we will send this to you in an email. You don't have to write this down. You're going to be listing out your name, your high school or middle school name, and what grade you're in. It should be no more than 500 words, single spaced. So that means one page, single spaced. The output should be a PDF or a Word document. You should be used to that from what you do for school. And the big question in it is, how has attending Mini Medical School changed or reinforced your plans to pursue a career in healthcare or health-related research? So that's what the reflection paper is going to be on. And that's what you need to do to become a member of the Youth Academy. And we hope that many of you, if not all of you, take advantage of that. So that's that. So as I said, don't worry, we'll send that out again. Also, tomorrow we'll be sending a survey out. If you attended less than all 6 sessions, you're going to complete that survey. You'll go to the end and you'll get your self-signed certificate, which you'll download, and you can check off which sessions you did attend and complete it. For those of you who did all 6 sessions, you'll get the signed certificate from Dr. Smith and myself, and we'll handle that in a separate transaction. So at this point, I'm going to go ahead and introduce this evening's speaker, which is Mr. Chris Otto, MSN, RN, CCRN. Chris has been a registered nurse in Delaware for over 10 years with experience in progressive care, critical care, heart failure, cardiovascular, open heart surgery, neurology, perioperative, leadership, shared governance, professional excellence, and magnet recognition. And Chris, I'll let you explain what the magnet recognition is at some point. Chris attended Wilmington University for his bachelor's degree as a registered nurse, and then Drexel University for his Master's of Science in Nursing and Nursing Innovation. That CCRN at the end of his initials stands for Critical Care Registered Nurse and is an affirmation of certification by the American Association of Critical Care Nurses. Chris, we'll turn it over to you. Thanks for joining us.
Awesome. Thank you, Tim, and the Academy Public Health Association for inviting me to speak with you tonight at the Mini Medical School. I'm super excited to be able to share my experience and some of the clinical knowledge that I've gained over years of practicing as well. There will be plenty of time for Q&A, as I understand, and we'll have some help in moderating that, but I do want plenty of questions come in, whether it's my experience in my journey or related to tonight's topic of heart health. With that being said, I'm going to go ahead and get my screen shared and we'll jump right into it. My current roles, I am registered nurse as Tim shared, and you can see in my credentials. I currently have two positions, sometimes three. My main one is I serve as the executive director for the Delaware Nurses Association. What that is we are the oldest, largest, and most inclusive professional association for all of Delaware's nurses. We're the state affiliate for the American Nurses Association, so we're connected to ANA nationally, as well as a network of over 50 additional state and territory nursing associations. So great network of colleagues across the country working to advance the profession and health. Additionally, I do still practice at the bedside. Right now, it's about 1 day a week. I'll actually be over at Christiana Hospital tomorrow. My current unit is the neurological intensive care unit. So right now, I'm primarily focused on strokes, brain bleeds, any tumors, whether they be cancerous or non-cancer in the brain, and operating, removing them and caring for those patients, seizure disorders, and then there's a number of rare neurological disorders that we see as well, like Guillain-Barré, etc. So a lot of experience in that space as well. And then occasionally I will find myself teaching future nurses as well, usually in an undergraduate program. So a little bit more about my story, even backing up further than Wilmington University. I am a native Delawarean, 30 plus years in the state, lived everywhere pretty much between Dover and Claymont. So certainly top half of the state. Graduated from Middletown High School in 2005. And then my first degree was actually at Delaware Technical and Community College in the Stanton campus, right up here by Christiana Hospital. Received an associate's degree in nursing. And then 2 months later, February of 2011, was when I actually sat for the national licensure exam and passed and obtained my license as a registered nurse. A cool thing about nursing is we have a choice, and there's 37 states that participate in a multi-state license compact. So I can actually take my education, license, training, certifications, and go practice nursing in New Jersey, in Maryland, Florida, a number of other states. I think approaching 40 at this point. From there, I continued my education as stated, went to Wilmington University, obtained my Bachelor of Science in Nursing. That was in the end of 2014. And then as stated, Drexel University, obtained my Master of Science in Nursing, concentrated in nursing innovation, and also did a post-baccalaureate certificate in health systems leadership. Career-wise, long before I obtained that nursing education and the licensure, I started working in healthcare. I've been employed with Christiana Care continuously for over 17 years now, coming up on 18. And I like to share that pathway because it's not one that I anticipated entering into. And sometimes life just happens that way, and you stumble upon the path that you're meant to go down. In high school, I was actually taking drafting courses and intended to be an architect, and was looking at colleges for that. Like most high schoolers, I, quit the job I had at Arby's and, hated it and went home miserable. Of course, my mom said, well, you need a job, get out there. So got connected with Christiana Care and started there as a patient escort toward the end of my senior year of high school. And that we just still very much an active role. You're taking patients, transporting them within in the hospital to tests, to different rooms, to discharge, etc. And that's where I really fell in love with healthcare and ultimately nursing. I worked directly with the patient care technicians and the nurses in the units when I was picking up patients or dropping them off, and really just, made some friends, observed, spent some time on the units, and realized that that's what I wanted to do. So I took a medical terminology course that was offered, and again, this is over 17 years ago. It's not even offered anymore, and became a unit clerk. This was before the electronic health record, so my job was to take the doctor's handwritten orders and transcribe them. Whether it was medications, I was writing out the medications that the nurses would then go and mark and double check and administer, document that they administered the medications, and another number of other responsibilities. From there, I knew I wanted and started to take prerequisites in nursing school at Del Tech. So at that point, I transferred and did more hands-on patient care technician on the unit next to the nurses, helping with activities of daily living, patient movement, basic care, etc. TCT2 is a combination of both of those skills of the clerk and the tech, doing both interchangeably. And then February 2011, obtained my license. And then my first nursing position was on a unit at Christiana Hospital called 5E. It is a cardiovascular intermediate care, so it's between the ICU, but not quite the general population of the hospital. And we specialized in heart, particularly in heart failure patients. So that's where I got my first certification. That's where I got involved in shared governance, working with my colleagues to identify problems, come up with solutions, etc., and continue to develop into that. After about 4.5, 5 years on that unit, I decided I wanted to take my skills clinically and build them further. So I transferred down to 2E, which is technically the cardiovascular critical care complex. It's the cardiovascular ICU at Christiana Hospital, and was just, working with pretty much the same population, but at a higher intensity of care, patients that required a breathing tube and ventilator to support their breathing, and some additional therapies that we'll get into when we start talking about some of the actual heart diseases. Concurrently, while doing that, I was also building my leadership skills through a model called shared governance. It's where us as bedside direct care nurses, we partner with leaders and, again, look at those problems, come up with solutions, lead them, etc. And that progressed to a system level shared governance role, which then ultimately translated into my first official leadership position. Technically, that was called Manager of Nursing Professional Excellence, as you heard, and magnet recognition in my bio. So I was not at the bedside anymore. I was working in a system, in an organizational level leadership position, doing a lot of program management. So we were looking at nurse experience within the healthcare system, satisfiers, dissatisfiers. I continued to support and grow the shared governance model. I did strategic planning for the Department of Nursing and some budget work. Patient experience as well was a big part of my role. And then probably close to half of it, depending, was around this program that Tim had mentioned, magnet recognition. So this is a national, actually international designation that hospitals and health systems can apply to, that they set the most rigorous standards for nursing excellence, for nursing quality, experience, outcomes for the patients and the families and the communities, really looking at the characteristics of the hospital and health system that lend itself to happy nurses, happy patients, and obviously really good outcomes. So it was a rigorous program that you had to apply to, with a document that ended up being hundreds and hundreds of pages if you were to print it out. And then you had a site visit from appraisers, from creditors that would actually come on site and make sure that you are walking the walk and not just talking the talk. And they want to see nurses, they want to talk to them, they want to talk to leaders, patients, etc. And then all that gets reviewed and you're awarded, hopefully, this designation that at this point still only 7 to 9%, I'm not sure what the latest stats are, but 7 to 9% of US hospitals and health systems have achieved this designation for their nursing teams. So it was pretty rigorous, but also learned a lot from there. And certainly, timing of the pandemic and other influencers, I then had the opportunity to take my current position as executive director for the Nurses Association. And I was also ready and missing the bedside. So I decided at that point to do this balance of, nearly full time with the association, but then, about one day a week still practicing at the bedside. And that's where I gained some experience in perioperative settings, working with surgical patients. And then now working primarily focused on the brain and neurological issues. Uh, Additionally, throughout my career, there's been a focus on those professional national certifications to continue to validate my clinical knowledge around particular topics. So the first one I received was actually CHFN, Certified Heart Failure Nurse. But I've been out of that for a couple of years now, so I let that one lapse. Same thing with PCCN, which means progressive care. So that's that intermediate care that I mentioned where you're not quite sick enough for the ICU, but not quite well enough for the general population. So that was the national certification to validate your knowledge and practice in that area. And then being that I still practice in the ICU, I maintain it and am very happy to have my certified critical care registered nurse certification. The thing with nursing is, and most health professions, physicians included, we are never done. It is a continual lifelong learning and professional growth and development opportunity. Just think about that in terms of the technology and the devices and the medications and procedures that are, constantly being tested and explored and then put into practice. We have to make sure that we are continuously learning, applying, and making sure patients are safe and outcomes are achieved. So for me, next steps, career, not sure this opportunity that I'm in now could open a number of different doors. We shall see where that goes, but there are other things that I know for sure that I'm currently working towards, and that is, yes, furthering my education, looking at my terminal degree in nursing, which is a PhD, Doctor of Philosophy in Nursing. There are other doctoral degree options for nurses. There's a DNP, which stands for Doctor of Nursing Practice. That is usually, but not always, more focused on our advanced practice registered nurses and those hands-on clinicians. That tends to be their preferred pathway towards that doctoral degree. But there's other options, EDD, SCD, there's a number. I have done the research and personally want to go for that PhD, as I do enjoy teaching, but also enjoy researching and contributing to new knowledge. So looking at University of Delaware, I want to keep it in state and stay local for that. So we're looking at next year for possibly starting. And then additionally, with my experience now and being almost 3 years into my current role as executive director, there are some leadership certifications that I'm looking at. First one being particular to nursing. There's a NEABC, that stands for Nurse Executive Advanced Board Certified. So that one demonstrates my knowledge, skills, and practice as a executive in the nursing and healthcare space, whether that be budgets and planning, people leadership, outcomes improvement. It really tests and validates knowledge around all of that. And then there's another cool one, because I do love working in the association setting and leading this work. So this one isn't specific to nursing or healthcare, but it's CAE. It stands for Certified Association Executive. So this demonstrates and validates my knowledge in terms of running the association. Again, budget, membership, programs, strategic planning, partnerships, all of those things that I need to do to, advance the association, our mission, our vision. So that's a lot about me. And now let's, just jump right into the meat of heart disease and, continue to share some of that with you. So why are we talking about it? Why could this be a week lecture instead of an hour and a half? Within the United States, heart disease is the #1 leading cause of death. Year over year, irrefutable. It has a significant impact on our health system, on our communities, on our budget and financial systems. It costs a lot of money. It costs individuals a lot of money when they are diagnosed with heart disease. So it is definitely one of the number one things that we're looking at within healthcare, and certainly need to talk about it a lot. So I want us to have just a pause before we jump into it. Quick mindfulness moment. I want you to just relax yourselves, get comfortable in your chairs, close your eyes if you're not too tired, and if you're comfortable with that. Ground your feet flat on the floor, sit up straight. I want you to take some deep breaths. Now I want you to slowly exhale. Slowly inhale through the nose. Hold that breath for 1, 2, 3, and exhale 2, 3, 4. Awesome. So I hope everyone feels a little bit more relaxed. I intentionally incorporated that, not because I'm a big fan of mindfulness, but because it sets the framework for what we're going to talk about. And that's the fact that our heart is a muscle that we cannot control. You were able to control your breathing. We can hold our breath when we're underwater or, having fun or whatever's going on. We can control our arms and legs, etc. I can stop talking whenever I want to. I can control those muscles of my mouth. You cannot tell your heart to stop beating. And that's a crucial thing to understand and really fundamental to when we talk about heart disease and some of the conditions that come out from that. Going to try and do your crash course in anatomy and physiology of heart disease so that we understand, the healthy heart before we jump into a sick heart and some of the conditions that come out of that. So fortunately, I do have a nifty little blue circle here that will help. I want you to follow on the screen. We're going to start on the left side with this person. We have red colors, blue colors. We see the brain up here, the heart right in the middle, which, fun fact, diagrams never get this right. Your heart is actually just slightly left of your sternum. Nonetheless, it's not directly in the center of your chest. And then moving down, we have the liver over here. We have what represents the gastrointestinal or GI tract, with some intestines there. We have our 2 kidneys, shaped like little kidney beans there. And then what these little grids represent at the top and bottom here, and they're everywhere. These are the capillary beds. So within the cardiovascular system, this is where the fresh, oxygenated, nutrient-rich blood then exchanges at the cellular level, whether it's in the kidneys, the stomach, the liver, our fingertips, our nail beds. That is where the actual exchange at the cellular level is happening with fresh oxygen, fresh blood, and then the exchange happens, and then the sort of old used blood and nutrients, particularly carbon dioxide, get transferred back up to the heart, and that's where we're going to start. So the blue side represents that used up blood, the blood that has been processed by the organs or the tissues and needs to be cleaned. So it is the low pressure side of our cardiovascular system. And then the red side, which is that nice, fresh, oxygenated blood, is that high pressure side. So let's say, the kidneys, they've used up their blood and now they have some stuff to get rid of. It's going to travel up through the veins. This is, if you look at your arms, you'll see some veins popping out. That's the low pressure side. They are carrying used blood all the way back up to the heart. This is a complex, system and highway of different veins coming from all over the body back into this single vein that feeds into the heart. It's called the superior vena cava. Don't worry, there's no test on any of this yet. And it dumps it into the right side of the heart. the heart over here. Now, if we look at the heart anatomy, there are 4 chambers. So this one here is the right atrium. This is where that blood gets dumped from all over the body. And then the right atrium will contract, it will beat and push it down through one of the valves into the right ventricle. The right ventricle is larger, it holds more blood, and it has a little bit of a bigger job to do. This right atrium, it just needs to beat and push it down to the bottom. This right ventricle, however, needs to beat and push that blood back up and to the lungs. So these two systems, the left side and the right side of the heart, actually aren't directly connected in terms of the circulation. First, that old blood goes to the lungs, and the lungs we breathe, we get rid of the carbon dioxide, and we inhale fresh oxygen. From the lungs, that then freshly oxygenated blood comes back and gets dumped into the left side of the heart, the left atrium. This is the image here. Now, keep in mind, I'm not going crazy. This is backwards, but when we're talking about anatomy, we're always talking about it from the lens of the patient. So we're now on my left side of the heart, not from how we're directly looking at it, on a screen, on an X-ray, or anything like that. It's always, the patient's anatomy. So left ventricle is here, a little bit bigger, has that fresh oxygenated blood. Its job is simply to beat and push it down into the left ventricle. This one's really important. The muscle here, so this lighter pink actually represents the muscle, and it's a little bit bigger. This diagram's not exactly accurate, but it's bigger because the left ventricle's job is to then pump that fresh oxygenated blood literally to the rest of the body, to our fingertips, to our toes, to our brain, to all the organs. This is now, we have entered, if we come back over to the left side of your screen, this is where we've entered the red area, the high pressure system. And it needs to be highly pressured because it has to get the blood all the way down to our fingertips and our toes. It can't do that passively. It takes active work. It takes the left ventricle constantly beating and a forward flow out of that left ventricle to push the blood to exactly where it needs to get. So again, just quick review, up through all of our veins into the right atrium, down to the right ventricle. This beats and then pushes it up to our lungs. Again, we're exchanging, getting rid of carbon dioxide, we're getting oxygen that is then coming back, entering the heart through the left atrium, pushed down into the left ventricle, and then boom, beats out to the rest of our body. And those organs, the tissues, they constantly need that supply to do all of the work that they need to do, all of the various functions that our organs do. So that's the basic crash course of the anatomy and a little bit of the physiology of the heart. Important to remember, 4 chambers, 2 smaller ones on the top, left and right, and then the 2 larger chambers at the bottom called the ventricles. We have the right and the left. There are additionally 4 valves that separate those chambers and prevent the blood as each chamber is pumping. Those valves close and they prevent any blood from going the wrong way, and continue that forward flow of blood through the circulatory system. So 4 chambers, 4 valves, low pressure veins, high pressure arteries. But that's not all. Our heart is also electric. So we can't move forward without also discussing briefly the electrical side of our heart. No, I am not talking about what you see in the movie. Don't believe everything you see. It is wrong. This video, I begrudgingly put it on here. It is terribly wrong. We don't even use those paddles like that anymore. Or even if we did, there's no gel on them. The bodies, they don't shake up like that when you shock them. It's not dramatic like that. But this is the electrical side of the heart. Just remember, don't believe everything you see on TV. Because all of us go crazy watching medical shows because they always get it wrong. And anyway, so brief look at the electrical system of the heart. This is what we can't turn off. This is why it's important to discuss, because this is always going, unless you're dead. But it is always going, and it starts in the left atrium with an impulse. Those cells depolarize, or they contract and send that electrical signal down a complex pathway of nerves, and tell the heart to beat in the order that it should. Of course, we want our atrium to beat first so that they empty their blood. We don't want the ventricle beating. We want it nice and relaxed while this is pumping, so that while it pumps, the blood can fill in the ventricle. And then the atrium doesn't beat. The valves close because of now this pressure in the ventricle, and the ventricle can beat and send that blood up where it needs to go. It's always atrium, or the top chamber, beat, and then that's the lub dub. Top of the chamber, the atrium beats first, and then the ventricle, or the bottom chamber after that. This is synchronous on the left and right side. So the left and right atria, the two top chambers, they contract together. The left and right ventricle, they contract together. It's always lub dub, top and then bottom. But remember, the right side is sending blood to the lungs, and then the left side is sending fresh oxygenated blood to the rest of the body. So they are beating together, but they are sending blood to two different places. So that electrical impulse gets started at the top, that right atria, that right chamber, and then moves down through this yellow pathway. And then these two bundles here, they are the ones that tell the ventricles and actually tell those muscles, the cells, to contract and give a heartbeat. And that's what we're seeing again on TV, or otherwise, the electrical recordings of the heart. This one is actually good. Kate and others can attest to, we see some heart rhythms on TV, and it's like, that is not compatible with life, but somebody's, talking, or a heart never beats that way. In any case, this one's a good representation here of what a normal heartbeat looks like. This first little wave there is the atria, the top of the heart contracting. The big one, as you can imagine, are those bigger bottom ventricles contracting. And then you see a little wave here after that is actually the ventricles then relaxing and filling back up and getting ready to do it all over again. We cannot stop this process. It keeps going and going and going. All right, so that's the heart, cardiovascular system in a nutshell. Not too shabby there. We will get to questions, and I can always go back to slides at the end as well. But what I do want to, talk about is, how do we keep our hearts healthy? Before we dive into the sickness and all the diagnoses and treatments and all the cool stuff, the first thing we need to do is prevent any of this from happening. And so I put in here from the Centers for Disease Control and Prevention, their framework around the 3 levels of prevention. First thing we have to do is primary prevention. We need to do everything we can as individuals to keep our hearts and the rest of our bodies healthy. Excuse me. So this is an intervention that we implement while somebody is completely healthy. We don't want them to develop disease, so we prevent that from happening. An example of this is working with individuals to make sure that we are exercising and eating healthy, that we're not eating McDonald's 3 times a day for the rest of our lives, that we're actually taking in a well-balanced whole food, nutritious diet, and that we're moving our bodies. That's just been an evolution of society as, we work more behind computers and whatnot. We're not moving and using our bodies as much. And those two right there are number one contributors to pretty much every, disease and illness out there. So primary prevention is just keeping people healthy. From there, we look at secondary prevention. This is where a disease process has begun, but somebody hasn't developed a symptom. So hypertension, what we'll talk about, is actually known as the silent killer, because your high blood pressure will go up and you will feel completely fine. However, it's going to lead to heart disease and other complications, kidney disease, all kinds of things. So the aim of secondary prevention is to identify and screen people and identify a disease before it gets symptomatic. So that's why when we go and have a checkup every year at the physician's office or with our nurse practitioners, we get our blood pressure, we get our heart rate. That is all just early identification, making sure that everything's normal. And then if we catch something, then we start to treat it. So again, keeping on the track of the example of diet and exercise, this is why, again, at those checkups, we always step on a scale, check our height, and then create the body mass index, which can tell us if we're overweight or obese for our body type. From there, tertiary prevention, this has now been, you've had a heart attack. Something has happened after the disease or injury. We've, gone in, put a stent in, whatever that case may be. The focus now is preventing it from happening again. Once you've had a heart attack, once you've had a stroke, it's essentially bound to happen again. And so the focus becomes preventing that from happening again. And this is where we actually put interventions in place to help those, with overweight and struggling with their weight, to lose weight, keep it off, get that activity back. So whether it just be coaching and, health style, lifestyle modifications, or there's certainly medications, surgical options, and other advanced treatment options to help people manage their body weight at a healthy weight. That is now focused on tertiary prevention. There's been an issue and we're going to treat it. So with that being said, lifestyle and risk factors for heart disease. There are with most all illnesses, there are non-modifiable risk factors, and then there are modifiable risk factors. There are some things that we just cannot control, and they're going to be there and affect our chances of developing heart disease. Number one, our genetics. If our parents, if our grandparents, they've all had heart attacks and we're coming from this strong line of heart disease, chances are you could be looking at one in the future. So genetics, not modifiable. They are what they are. We control that, though, by tending to and focusing on those modifiable risk factors. Other thing, age. Older you get, more likely you are to have heart disease or other complications and diseases. Gender, you can't control that. So at gender, with heart disease in particular, men have the higher risk of developing heart disease up until women experience menopause. Then it kind of levels out a little bit, but generally men have higher chance of developing heart disease. We also can't change our ethnicity, and that kind of ties back into our genetics, but we can't change that either. And when it comes to heart disease, African and Asian ethnicity do carry a high risk for developing heart disease. That's what we know from the research and statistics. Now, moving into modifiable risk factors, the things that we can control, first and foremost, we can choose not to smoke. And yes, that does include vaping, e-cigarettes, all of that. Significantly, number one risk factor, modifiable risk factor for developing heart disease is the use of nicotine and other smokeless or tobacco products. So so much effort and focus on helping people to quit, stay quit, or never pick it up in the first place. From there, blood pressure is actually modifiable. Yes, it's genetic as well, so you can develop high blood pressure, from genetics and a number of other causes, but we can control it with diet, exercise, medications. We can keep that blood pressure down at a healthy level and, prevent further complications. Same thing with our cholesterol or lipids. I put both there because we hear a lot about cholesterol. You're in many medical schools, so it's okay to say it's a little more complicated than just your cholesterol. That is a level that we monitor in your blood work. However, there are also good and bad cholesterol. There are triglycerides. There's a whole panel that directly relates and can increase your chance of having heart disease. So again, it's another genetically and other other risk factors influence your chance of developing high cholesterol or hyperlipidemia is the medical term for it. But we can control it. Again, diet, exercise, and medications can get those levels back down, keep them down. Even myself at 35 have had periods where my cholesterol was high. I get it screened every year as part of routine blood work, and cholesterol has come back high. I said, oh, heck no. Diet, exercise, watch, how much fast food, processed food I'm eating. And guess what? Those levels are back down. So don't even have to go the medication route, but it's something that we need to be screening regularly and modifying. From there, you've heard me say it, diet, exercise, our weight, keeping that within what's appropriate for our body size, our height, our composition, etc. And diet is certainly the biggest. I mean, it's not rocket science. We understand that what we are ingesting, what we are putting into our body directly correlates then how that body is going to react, process, and evolve over time. So two extremely important modifiable risk factors. The physical activity, won't get on the soapbox, have said it enough, but that absolutely impacts, our chances of developing heart disease and a number of other complications, health complications. Alcohol, excessive consumption of alcohol is a modifiable risk factor that leads to heart disease, as well as obviously liver disease, kidney disease, a number of other issues, but directly tied to heart disease as well. And then just the presence of other diseases themselves, like diabetes, hypertension, hyperlipidemia, they all contribute and can increase to our chances of having heart disease. However, we consider them modifiable because those diseases, including diabetes, with the right treatment plan, we can get them under control and prevent those complications like heart attacks and strokes from happening. Diabetes, heart attack, stroke, very closely connected. All right, so that's the basics of our anatomy, how to keep our hearts healthy and prevent heart disease. We've done all that. Our genetics are working against us, and now, Houston, we have a problem. So now is the point where I'm going to talk through and we're going to highlight some of the most common heart diseases, and then, treatment and things like that, and we'll continue to move through. But this is where we'll jump into some of those fun treatment options eventually. First up, number one, most common risk factor for heart disease and extremely huge problem across the nation. Over nearly half, I apologize, nearly half of US adults have hypertension or high blood pressure. So this is where we go back to that diagram, and we're talking solely about the arteries, that high pressure side of the heart that is receiving the freshly oxygenated blood from the left ventricle and distributing it to the rest of the body. The pressure within those arteries becomes too high. We need a certain amount of pressure in there to keep that forward movement of blood flow, Again, because your heart's not constantly contracting, it's beating, and that's what's creating that forward flow and getting that blood down to our fingertips and our toes. But eventually, and like I said, unfortunately, very commonly, that pressure gets too high. And there's a number of things. We just went through all those risk factors that causes the pressure to get higher. One that I didn't mention, but is very common and definitely linked as well, is our mental health. So are we stressed? We're running around very anxious and stressed out, shoots our blood pressure up. Number of things influence that. But it's also important to know that throughout the day, our blood pressure does normally fluctuate. If we are working out, we've just come from a big run, depending on if you're seasoned athlete or not, your blood pressure might be a little bit higher. If you just took 3 flights of stairs, your blood pressure is going to be a little bit higher by the time you're done with that, because you were using more oxygen, your organs were working faster, the muscles in your arms and legs were, getting you up those steps. So that required more oxygen, more resources. So the arteries compensated and they got tighter. They increased the pressure to keep that blood flow going. When we're sleeping, we're not expending as much energy. So normally our blood pressure is much lower. Said number 1 risk factor, half of US adults have hypertension. Really concerning statistic for all of us in healthcare. Only 1 in 4 have their high blood pressure completely under control, meaning you can walk into an office or take your blood pressure at home at any point, and you're looking at controlled or normal numbers. There's no bonus points, but I don't know, Tim or Kate or Nicole, if you can type it in the chat yet. If anybody wants to type in the chat, what do you think is the normal blood pressure? What's the recommendations? And let's see what we pop up there. While you're typing that in, and before I give you the answer or too much time and you start Googling it, ways that we control our blood pressure is, again, diet, exercise, making sure we're getting enough sleep, making sure that our stress is under control. If we have high blood pressure, making sure that we're taking our medications as prescribed. Nicole, I saw you pop up. What kind of answers are we getting?
We have 120 over 60, 120 over 75.
Everybody's right. So the normal blood pressure is less than 120 over 80. So the 120 being our systolic, or the pressure in the arteries when those ventricles are contracting. And then the bottom number is called the diastolic pressure, and that's the pressure when everything is nice and relaxed. You need both of them to keep that forward flow. So yeah, 120 over 75, 120 over 60, all great numbers. 100 over 60, anything less than 120 over 80 is a good blood pressure. So that's why we get it checked so frequently, and we, aim to keep it under control. So that's how we do it. All of those things that I just listed. And if we don't keep the blood pressure under control, one of the most common types of heart disease, not one of the most common type of heart disease, is then coronary artery disease. So you've heard me say arteries, that's the high pressure side, feeding all the blood. The heart needs fresh blood itself. The heart is a muscle, it never stops working. So right as the left ventricle pushes blood right out of the chamber and into those arteries, there's these little itty bitty ones right off that branch off and then circle right back around, and they are the coronary arteries. They take that fresh blood and they feed it right back to the heart muscle so that it can continue doing its work. So obviously very important. We can't tell our heart to stop beating. It needs to continuously get that fresh oxygen and nutrients. However, if it's diet, inactivity, genetics, age, what happens in those arteries is over time they can become narrowed or completely blocked. So a nice artery that was open then starts to get a lot smaller and narrowed, making it harder to get the blood through it, making it harder for the heart to work to get the blood through it. And that ultimately has a downstream effect. So again, most common type of heart disease, this leads to heart attacks. There's another slide on that, so I'm not going to talk about heart attacks right now, but coronary artery disease is what causes heart attack to happen. The coronary artery disease itself becomes worse over time, progressive if it is not managed and treated. So again, looking at those risk factors, high cholesterol, high lipids, etc., and treating them so that we prevent more plaque from building up and further narrowing that artery. Save that other piece for heart attacks. Symptoms of coronary artery disease: chest pain, heaviness, people are leaning over, they're saying, I can't catch my breath. It feels like there's an elephant sitting on my chest, whatever that may feel like. Lightheadedness, feeling like they're going to pass out. Maybe, depending on how severe it is, it might affect their vision. Certainly nausea and vomiting, because again, the blood is not being circulated as effectively. How do we treat and control coronary artery disease? If it's not bad enough to the point where it's at a heart attack, we control it with diet, exercise, sleep, stress, and medications. That hasn't changed from hypertension. All of those things aim to keep it under control, keep it from getting worse, and actually some of the medications help to open back up and relax those coronary arteries so that they can get the blood through easier. Fun little sidebar, but totally related conversation. Even as our bodies continue to age, our bodies have this internal checks and balances system. It is always trying to compensate for, an issue that it has identified. Our immune system is constantly checking, scanning our bodies. And so even in heart disease, and particularly in coronary artery disease, over time, your body will actually build, essentially, putting this very plainly, new arteries around a narrowed or blocked artery to get fresh oxygen to that heart muscle, to the area that is currently blocked off from coronary artery disease. When we look at a cardiac catheterization and we're shooting dye into those arteries and seeing if they're blocked or narrowed, we can actually tell, we call them collaterals, that the patient has developed collaterals around a blockage. And that happens as an adult, as we are developing coronary artery disease, another silent killer. You don't know you have coronary artery disease unless you're symptomatic, have had a heart attack, etc. Now, speaking of heart attacks, the term is myocardial infarction. That is what we will call it, and then what it is diagnosed as. We all know it as a heart attack. This is now completely obstructed blood flow to the heart muscle in one of those arteries. It could be one. Sometimes patients have it really bad and there's multiple blockages. And also, just like you can imagine, in a network of these arteries, where that complete obstruction occurs is also going to determine how bad the heart attack is. If it's in this little itty bitty artery that's right at the tip of the, before the capillaries, and it's just feeding this little piece of heart muscle, you're probably not going to be very symptomatic with that. Actually, we see patients that have these silent heart attacks. They come in because now they've had a big one, and we look and actually your muscle over on this side is scarred. You probably had a heart attack over there. So if it's a blockage in one of the larger arteries that is feeding other arteries in the heart, well, now you're talking severe chest pain, probably even cardiac arrest. The biggest one that feeds the left ventricle, we call it the widowmaker. When there's a blockage in that particularly large artery, you can forget about it. Most of the times somebody comes in cardiac arrest, and then we'll talk about what that happens and what that looks like. But the widowmaker is what we call it. just like with strokes, heart attacks, we say time is muscle. The objective as healthcare providers is to do everything we can to get the patient to treatment that removes or opens up that blockage. Most of the time, what that looks like when someone's having an acute heart attack is we take them to the cardiac catheterization lab, we insert a catheter, they thread it up and shoot dye directly into the arteries using X-ray machines. The physician identifies, okay, that's where the blockage is. They can put a different catheter up through there and actually thread it through. Depending on if it's a clot, which you can tell, they have a device, particularly in strokes, that can go in and actually grab the clot and pull it out. If it is a ruptured plaque, so we talked about plaque buildup, what happens, unfortunately, and over time is that plaque can actually rupture and completely close off or obstruct that artery. If that's the case, then the treatment option is to put that catheter in, try to get it through that obstructed artery and use a balloon to actually blow it up, open it up, and then you put a stent, kind of like scaffolding, into that area, and that restores the blood flow. So time is the muscle. The sooner we do all of that and restore blood flow to the muscle, the better the patient is going to do. If we can't, get to it, if there's complications, if it's too long, too extensive, unfortunately, what ends up happening is that area of the muscle essentially dies off. It is no longer beating. The rest of the muscle around it is. So as you can imagine, there's a certain point where your heart can take a little bit of an injury and keep going without you noticing it. But then more extensively, if larger portions of your heart muscle are essentially dying off, then you're going to have a lot more complications, and we'll talk about that in a few slides. Alarming statistic, every 40 seconds in the US, someone has a heart attack. So we've been at this for nearly an hour. I should have calculated beforehand, but who knew? Every 40 seconds, someone has had a heart attack. Symptoms are very similar to coronary artery disease in terms of that chest pain, the lightheadedness. What we see more common is radiation. You might see someone holding, oh my God, my shoulder, my whole arm, it's coming to my back. The thing with these symptoms are in a heart attack, they usually come on very suddenly. So somebody's well, and then boom, they're down with, excruciating chest pain. That's because you are literally watching the point where that blockage has occurred, and now the heart muscle isn't getting oxygen. How do we control it? Same thing. Once we restore the blood flow or determine, we can, it's not in a super big artery, whatever it is all about diet, exercise, sleep, managing your stress, and taking your medications. Again, preventing it from happening again. So now, one of the worst, cardiac arrest, medical terminology, AKA you're just dead. Your heart's not beating, nothing's happening, no longer pumping blood. What do we do here? Call 911 and you start CPR. Hopefully, at this point, you've all had some CPR training or some exposure. Everyone needs to know it for this statistic alone. If somebody has cardiac arrest at home, outside of the hospital, far away from emergency medical services, they are more likely, unfortunately, that they're going to pass away from that heart attack. Again, this is time. Time is muscle. This is our brain, this is our organs, this is our heart, all going without that fresh oxygen circulation. So what CPR does, what that manual pushing on somebody's sternum over top of their heart, is it is doing the beating for the heart. Again, comparing to TV and reality shows and whatnot, you see people always giving breaths and kissing them, and they wake up and it's a miracle. That doesn't happen. The reality is you need to get on that person's chest as soon as you determine that they're in cardiac arrest, you can't feel the pulse, and push hard and push fast on that chest, because our blood actually contains certain amount of oxygen that it doesn't even use. It's reserve oxygen. So what the research has shown is you don't need to help someone breathe right away. That's not the first step. The first step is to circulate the blood. And then after 2 minutes of that, then you give somebody an assisted breath, mouth to mouth or device, and help get more oxygen into the bloodstream and circulating. It can be reversed. I haven't met a patient yet after cardiac arrest that has seen the light. So again, don't believe what you see in the movies. But we do get patients back all the time, get them back. Meaning that we've done CPR, we've given them medications, we've treated whatever the underlying cause was, and restored the electricity, restored the heartbeat. Really good. So can be reversed, no light. If reversed though, however, this is again, time is muscle. The longer that somebody stays in cardiac arrest, heart not beating, we may be giving them CPR and it's effective and we're doing all the treatments that we can as healthcare providers. The longer somebody stays in that state though, or without the CPR support, maybe they went 5 minutes before somebody started chest compressions. However, we still got them back. So this is where, yes, technically you talk to people and they're like, I was dead for 5 minutes. They were, they're not lying. What that results in though is potentially brain injury, kidney, organ damage, and a number of other complications, not even including post-traumatic stress and the mental health burden of, having lived through that. But the number one that we talk about is brain injury. So again, your heart's not beating, maybe we're giving chest compression, it's effective, we got somebody back. That is time that those muscles, cells, etc., did not have oxygen in blood. So that can lead to brain injuries where, somebody's struggling with a host of complications, seizures, etc., difficulty walking, all kinds of issues because the brain itself was deprived fully of oxygen for an extended period of time. And that has now caused all these complications. So symptoms, what are the symptoms of cardiac arrest? You're dead. There's no symptoms. You're pulseless. Somebody's laying there. Nothing's happening. That's your symptom. Call 911, get on the patient's chest and start that CPR. Don't go right for breathing, 2 minutes, pumping hard and fast on somebody's chest when they're passed out. And get the emergency medical team there. Something I am still particularly passionate about, and am active in nationally with the American Association of Heart Failure Nurses, is heart failure. The medical term for it is cardiomyopathy. And from there, there's a host of other complications. Ischemic cardiomyopathy, non-ischemic cardiomyopathy, dilated, diastolic, the list goes on. But basically all of that means, what cardiomyopathy means is the heart is pumping. It is just not effectively pumping. It is not meeting the demands of the body. So again, we know our toes, our fingers, our organs, they're all needing and essentially demanding that fresh blood. The kidneys have this cool linkage with the heart and compensation system. When the kidneys sense that they are not getting the blood that they need, they actually release hormones that cause the blood pressure to go up so that more blood is forced back to them. So the body is continuously monitoring this. It needs the blood. And so when the heart isn't able to meet the demand, a host of complications and things happen. One of the important statistics around heart failure, that despite decades of advancements in research, have not been able to move this statistic. Out of all the people that are diagnosed with heart failure, 5 years after that initial diagnosis, over half of them are going to have passed away. It is a heavy burden on the individual, on their loved ones, healthcare system, and beyond, because it carries such a high mortality. And just because you're alive doesn't necessarily mean that you are, functioning and living the best quality of life. So even in that 5 years, you're probably in and out of the hospital. You have a lot of different medical office appointments, etc. And so very burdensome disease that, again, the focus is on preventing it from even happening. And then if it happens, really working closely with the patient and their support system to manage it effectively, keep them out of the hospital, and do everything we can to give them the best quality of life, and figure out what that means for each of them. So again, I could go on for this forever. Several different types of heart failure. Sometimes it's the ventricle, sometimes it's the left side of the heart, sometimes it's the right side of the heart, sometimes it's a valvular issue, that all essentially causes the heart, that system, to not efficiently and effectively pump blood to the rest of the body. You can have multiple different types. You can have diastolic and systolic heart failure, etc. Some of the symptoms, number one is centered around breathing. Patients have trouble breathing when they're laying flat. They need to sit up and breathe. Sometimes they're leaning over because it's easier for them to breathe that way. They're, go for a walk. They can't talk and walk at the same time. They go up a few steps and they have to take a break and catch their breath. A lot of things around breathing, again, because the heart is not pumping effectively and the lungs are demanding, the lungs are saying, I need oxygen, breathe more. But it's just a bad situation to be in. Patients are generally fatigued, extremely tired, lots of naps, long sleep, not usually good sleep because, again, they're having trouble breathing at night and they can't lay flat. And then additionally, water retention. The kidneys aren't getting and circulating enough. So eventually our body starts to hold on to water. That's where you see the swollen feet, swollen ankles, big old bellies, all kinds of places that our body can hold on to water, including our lungs. Our unfortunately, with our heart failure patients, it is, the breathing is so bad because there's actually water being built up in the tissue that is then preventing them from breathing effectively. From there, controlling it, again, this is about, tertiary prevention. You have this disease. How are we going to manage and prevent it from getting worse? Definitely diet, controlling your salt, taking your medications. This is one of many diseases that it's just not an option. With medicines, even if you are feeling great, you have to keep taking them. And then really getting connected with interdisciplinary medical team, physicians, nurse practitioners, nurses, case managers, social workers, etc. From there are a lot more advanced treatment options. This is now where we are actually talking about and looking at heart transplants. Somebody can get their heart transplanted here in Delaware, and some of the nursing that I did, we can actually implant a mechanical bypass system, surgically, open heart surgery. Surgeon goes in, cuts open the sternum, operates on the heart. Above that left atrium where the blood is coming out, we are actually sucking it out and sending it through this little turbine, little spinner thing, and then sending it back out to the rest of the body. So we are doing in many cases permanently, until somebody passes or they get a heart transplant. That device is in there and it is coming out through the abdomen with a little cord connected to a system, connected to electricity, and that's how that patient lives. So lots of advanced treatment options for heart failure. Getting back to our electrical abnormalities, we have atrial fibrillation, more commonly known as AFib. This is where the top chamber of the heart, the atrium, hence atrial, is beating irregularly. It's not the lub-dub, it's not atrium chamber or atrium ventricle. it is kind of going crazy up here, and then the ventricle is still just down there beating normally. So this is a disconnect in that electrical pathway. The top chamber, the atria, is just going crazy. It is firing on all cylinders, and it is not in sync with the ventricle and the rest of the circulatory system. So that complete disconnect. This is actually more common in individuals of European descent, and highly correlated to strokes. So what happens in that top ventricle while it's up there quivering and just going crazy, it's not beating synchronously, the muscle's just going crazy. You can imagine the blood is not moving through that chamber, that system, like it should. So blood can actually cool or kind of just become stagnant and get stuck in the atrium. And what happens, long enough is that blood then begins to coagulate. It begins to clump together, all the little red blood cells clump together, and they form a blood clot. And then poof, all you need is that one muscle going crazy on the atrium to just, push that clot far enough out that it gets put back into the circulatory system. Boom, travels up to somebody's head, and now they've had a stroke. So anybody that is in permanent or continuous state of AFib, we are putting them on blood thinners because we know it is going to prevent them from having a stroke. Some of the symptoms that patients have or describe when they have AFib is they can actually feel those palpitations or their heart beating irregularly. Again, they're just very tired. The blood's not circulating like it should be. They're feeling lightheaded or like they might pass out. How do we control it? Once you have it, you need medications to slow down how frequently and crazy, essentially, that heart is beating. You need the blood thinners to keep that blood thin and prevent stroke, and you need regular care. You're getting regular checkups, EKGs, and other tests to confirm and monitor your response to that atrial fibrillation. Uncontrolled atrial fibrillation can actually lead to heart failure. So another cause there. So heart disease is like the Great Wall of China. Unfortunately, the list goes on. Aortic aneurysms, peripheral arterial disease, pulmonary hypertension, valvular diseases, and then we didn't even get into the congenital heart defects or birth anomalies. So little babies that unfortunately, whatever reason, did not develop fully and have different abnormalities with their heart. Some babies come out and it's literally only one top chamber and one bottom chamber. Sometimes the valves aren't formed. I don't even understand all of them, and I've done it for a long time, but congenital heart defects, huge problem in heart disease and with our young ones, lots of surgeries and lots of support over the lifetime. So we can't get into all of them, and I definitely want to leave some time for questions. So we're going to go over quickly, how do we diagnose heart disease? There's a number of different ways. Number one, talk to your patient and family. Ask them what kind of symptoms they've been having, what kind of history. Is this a known problem in your genetics? We're looking at your age, we're understanding you're at higher risk, etc. Talk to the patient and talk to the family. Unfortunately, us healthcare providers, we are always wanting the family in there because we can have, as individuals, a tendency to minimize our problems. And it really wasn't that bad. For our family is sitting next to us saying, you were snoring the whole darn night. I didn't sleep a wink. Stop lying. That's, out of control. So the families tend to, give us the actual truth, where sometimes the patients can, well-intentioned, it's not a bad thing, minimize those problems. So we got to talk to both the patient and the loved ones. From there, we need to physically examine the patient. This is where we look at them. We are looking to see if they have swollen ankles. Is their skin kind of cold and clammy? Because again, the heart's not pumping effectively. We feel, is it cold? We feel for the pulse. Okay, we're trained and we feel for the pulse. Okay, is it regular? Oh wait, no, I think I felt an extra beat there. If somebody's in atrial fibrillation, that beat It won't be a nice lub dub, it'll be irregular, etc. Is it kind of faint and thready versus a nice strong pulse? And then, of course, we listen, break out the good old stethoscope, put it on the front and back of your chest, and listen to the heart. We're trained in exactly what those normal heart sounds are, and then from the abnormal heart sounds, we can actually identify which valve or which area of the heart is affected. From there, we move into some of the diagnostic testing. So always starting with our good old blood work, send you out to the phlebotomist and do a full panel. Look at your kidneys, look at your electrolytes, blood sugar, look at those lipid and cholesterol levels. All of those things that we know are tied into heart disease we are looking at. And heart attacks and some even heart failure, there are other specific blood tests that we can do to look for a heart attack. So there's a blood level out there called troponin in heart attack patients that the muscle is deprived of oxygen, it is starving. In an attempt to compensate, it releases this hormone called troponin, and we test it out. Very specific to the heart, but not always. A little caveat there. When you enter healthcare, you'll find out it's never really 100%. But anyway, troponin can tell if somebody's having a heart attack. There's some other blood work that can tell if somebody's having a heart failure exacerbation, if their body has developed a blood clot. There's all kinds of things we can do there. When it comes to heart disease, most common basic thing that we can do, and even at certain ages becomes part of that routine screening, is a ECG, more commonly known as the EKG, and actually electrocardiogram, so it is a C, not a K. But anyway, that looks at that electrical rhythm over a period of time, and from a number of different views or angles into the heart. That's why we place leads all over your body, because they are giving us a different angle that we are looking at the heart, and can diagnose from that where on the heart muscle somebody is having a heart attack. Additionally, x-rays, you take a picture of someone's of their chest, they've got a big old dilated heart sitting there, we know something's going on. We can tell the difference from an x-ray of a normal sized heart versus a heart that the muscle has enlarged in an attempt to keep up with that blood flow, the blood flow demands. Ultrasound or echocardiogram is what we're really looking at. That is an ultrasound of the heart, looking at the chambers, the valves, the opening and closing, flow, the muscle itself, diagnosing, is it enlarged, is it not? And then additionally, CAT scans and MRIs of the heart can help diagnose a number of other heart diseases. And then from there, we're moving into the more invasive procedures, like a cardiac catheterization, where you're putting somebody into sort of that twilight sedation. You are inserting a catheter. Nowadays, we can do it right through the wrist, put a catheter in there, thread the catheter up through the veins and to the heart, and look at those, through the artery, insert the catheter through the artery and look at and shoot dye and see how that blood is flowing throughout. So towards the end here, how do we treat? Number of different ways, but we always start with the least invasive, the least expensive, etc. And that is how we can modify our lifestyles, getting to the diet, the physical activity, managing our stress, getting enough sleep, all those things that, again, go back to preventing this in the first place. They all are critical in terms of treating heart disease, because the focus is keeping it from getting worse and or happening again. Same focus with medications. This is where we are giving you blood pressure medicines to keep that down, cholesterol medicines to keep that down, a beta blocker to keep the heart rhythm and under control. There are anti-arrhythmic drugs that help to settle the over electrical activity of the heart, the blood thinners, the list goes on. Number of new and emerging medications that help to treat different heart diseases. And then a big one is cardiac rehabilitation. These are trained physical and occupational therapists. I think there's even some programs out there right now that you come out as a cardiac rehabilitation specialist, working with patients in the outpatient or the home setting to get back to the physical activity, safe exercising, etc., to support the heart. Procedures, we are going in, somebody with AFib, we can actually go in, same concept with that catheter, thread it up to the heart muscle, identify maybe the most active area of the heart muscle that is causing it to quiver, and burn it. Actually go in, burn the muscle, get rid of that nerve that is overreacting, and sometimes, get people out of AFib if we burn the tissue that's causing it. So that's one example. We can go in and treat patients' valve diseases now through a non-invasive procedure. A number of different ones. AFib, we actually will go and shock patients, not with the paddle, there are stickers that go on now. And we'll shock the patient and hope that it restores a normal electrical activity. Devices, we can actually, there's a number of temporary or permanent devices that we can implant in people's bodies to monitor the AFib, to shock them if we know that they've already had a cardiac arrest in the past and they're high risk of having another one. Pacemakers to help keep that heartbeat regular and etc. at a certain rate. Sometimes patients' heart rates go too low and we just need that little extra support, electricity. So we put a pacemaker in there. There's these little pressure sensors that we put in now that can actually determine if somebody is retaining fluid during heart failure and they're starting to retain fluid. That little pressure sensor can send over a daily reading to the medical team and boom, we know, give you some more diuretics. Additionally, advanced therapies, I mentioned some of them, heart transplant, we call it mechanical circulatory support, where we are actually bypassing the heart and doing the pumping, externally to support the patient's circulatory system, number of others. But with that, I know I'm coming up to 8 minutes here. So hopefully you're not all feeling like this gentleman right now, that you're engaged, you're not overwhelmed. Certainly that you're, hopefully he's not in cardiac arrest, but in any case, if you have questions, we can take them now. And additionally, I put information up there. If you have particular interest in nursing or other careers, happy to connect with you. We too are on social media, so you can follow, get connected there, get a little insider glimpse into what nursing is like. So
Thanks,
you, Kate.
Chris. That's great. I love the final picture. We do have quite a few questions for you, so I'm going to get right to it. And this is one of my favorites. What if you break the sternum during CPR?
Oh, well, it is. All right, I have a couple different answers for that. One, Kate, is my first thought is it's traumatic for us. And I have done it in the past. I will do it again in the future. It is a lot of things in healthcare. We look at what's the greatest benefit versus the risk. And if somebody's in cardiac arrest, they're not alive, they're already dead. It doesn't get any worse than that. So if we crack the sternum, if we crack some ribs, but we restore the patient's heart and their life, then that's the greater benefit. Broken bones, they heal. So we crack a sternum, we crack a rib, they heal.
Yep. Next question, concerning the non-modifiable factor of gender. After someone has a sex change operation, does their risk factor remain that of their original gender, or is it influenced by their new gender?
I appreciate that question, and the answer is it's very complicated, and there is an entire specialty field of medicine there, but generally, it depends on the hormone replacement that the individual is taking, what they're tolerating, and I don't even want to give a general answer there. It's just complicated because you are now working with both of those hormones and genetics in your system. And so it just tends to be whatever one is more prevailing. Some people don't tolerate, certain higher levels of hormone replacement. And so it both will affect. And then additionally, let's go to the next question. It's very complicated.
Sure.
I'm thinking of other diseases now.
It is. I'm doing the same thing. Can heart disease start from a problem with the lungs?
Yes, they are connected. So if somebody has lung problems like COPD, asthma, I think I had on there pulmonary hypertension, is high blood pressure within the pulmonary arteries themselves. It is all connected. So if the lungs themselves are overpressurized or they're struggling to perform, that is going to back up. And the most common heart complication from lung disease is right-sided heart failure. So that right side that is attempting to pump the blood to the lungs, but is meeting a lot of resistance, is really struggling, that right side is going to try to compensate. The muscle will get bigger over time to try to increase the squeeze, and eventually, like a rubber band, you lose elasticity, you develop right-sided heart failure. So yes, heart disease can also start from certain types of lung issues.
Can sudden weight loss cause problems for the heart?
Sudden weight loss. So, I'm certainly thinking about, bariatric surgery and other where, we are losing that excessive amount of weight over time, or even, more plastic surgeries. Necessarily, I don't, Kate, correct me if I'm wrong from your family medicine perspective, but I don't believe there's a high correlation or risk there with a quick amount of weight loss. Now, somebody that already has heart disease that is going into and having like a bariatric surgery or other bypass or, treatment for weight loss certainly needs to be monitored very closely. But in a healthy person that loses that amount of weight quickly, I'm not aware of anything.
Yeah, I can't think of anything either. Do you see AI fitting into your part of the nursing field?
Oh, absolutely. I'm already using it. We're using it big time. Clinically, there's a lot of application in terms of those risk factors and assessing patients. So putting, large amount of patient data into an algorithm or, certain prompts, then can inform us as clinicians who's at the highest risk in our, a physician or a nurse practitioner might be assigned, 1,500 patients or 1,000 patients, using AI to put updated patient data and then have it come back out and help prioritize for that clinician what patients are at a higher risk, who's not being managed well, et cetera, who hasn't filled their prescriptions, that kind of stuff.
Do you think CRISPR can help modify genetic risk factors?
You put that in there, Tim? Gene editing, absolutely. Gene editing, absolutely. Primary focus with CRISPR and gene editing right now, certainly around cancer and other immunotherapy treatments, but there are certainly applications and cases and research happening out there in terms of heart disease prevention and management, particularly in those more advanced cases where you're looking at heart transplant, gene editing. Yeah, absolutely.
Yep. Talking about the conduction pathways of the heart, do they travel through the valves?
No, they do not. These are particular nerve pathways that carry and conduct the electricity exclusively and then transfer it directly to the muscle. So the valve itself is contracted, or no, valves are pressurized. So no, it's the muscles, and then as the muscles, the chambers contract, is what the pressure of a ventricle contracting will close the valve above it. So did that answer the question?
Yeah.
Trying to do this quickly.
Have you seen any COVID-related myocarditis patients?
Oh, absolutely. COVID, birth, we didn't even talk about, but there's a postpartum cardiomyopathy. So even just having a baby can lead to heart failure. And then, yeah, we certainly saw a lot of it in COVID. Interestingly, because of my peers knowing my background, both in heart and now neuro, when we get a patient in my current ICU that's having a stroke or some primary neurological issue, but we've had them with COVID, they had a stroke, but they also had heart disease, they would be, Chris, come over here. I need your input on this patient. Can you take care of this patient? Because you've got a dual focus there. So, yeah.
Why do Africans and Asians have a higher risk for heart disease?
Genetics. That is that there are many scientists out there much more knowledgeable about that than I, but it is absolutely genetics. It is the way that over the centuries, I mean, we're going back hundreds of years when we answer that question and think about the cellular changes that those ethnicities experienced to survive and grow in the geographic locations that they are located. Where we live affects our health. That's environmental health, that's public health. So that plays into the question around Africans and Asian ethnicities higher risk, because it is simply where they live and how their body had to adapt over time to survive and grow in certain conditions.
Well, Chris, I want to thank you for coming and talking tonight. This was a great presentation. There were lots of good questions. People have been saying already that it's been a great presentation. I appreciated it. Tim, I'm going to hand it over to you because it is our last session. So I don't know if you guys want to say any goodbyes, but I would like to thank everybody for coming to MiniMed and sticking with us all the sessions. And we hope that you're going to come back and do another round of MiniMed with us. Chris,
right. So I echo Kate's thanks to you, Chris, for the great presentation, and to all of you in the audience for attending. Again, we kept the numbers up right until the very end, which is always a sign of a great presentation. Much appreciated. So tomorrow, people will be receiving emails from us with further instructions and links to surveys and all that kind of fun stuff. And as I mentioned, all of you should have received an email about registering for the next series that starts next Tuesday. As Kate said, truly encourage you all to attend. It's different topics, different speakers, and there will be the physical therapy speaker that we did not get to hear this time, who will be presenting in the next series. Again, thank you to everyone. Have a great evening. Talk to you later.